Okay, we might get started just because it's 10 o'clock now in the interest of time. So tēnā koutou katoa. Good morning, everyone. My name is Dipna Mulroy, for those of you that don't know me, and I'm the Motor Neuron Disease Research Network Manager, and I'm also the curator for the MND registry in New Zealand. I'd like to warmly welcome you to our final New Zealand MND Teleconference for 2021, and it's certainly been a challenging few months for some of us since the last lockdown, or since the last teleconference, because we've really been in lockdown since then, and I'm sure that many of you are looking forward to some freedoms in the weeks ahead, all going well. This morning I'm delighted to welcome our guest presenters, Dr. Leigh, Dr. Alan Stanley, Dr. Mandy Wilkinson and Justin Jordan. I'd also like to take the opportunity to thank Motor Neuron Disease New Zealand, who fund the MND network, and without them we would be unable to provide this information to you today. If this is your first time joining us, the MND Research Network was established in 2017 and clinical researchers, allied health professionals and other researchers who will have an impact on MND. As New Zealand is such a small country, a collaboration is important to help accelerate and broaden MND research, and we're always interested to know what research is happening locally, and we encourage people who have an interest in MND research to please get in contact with us. You can connect with us via social media, Twitter, Facebook, and also via the website. These are regularly updated with events that are happening locally and internationally, research opportunities that are available, and any resources as well that might be of interest to researchers. If you're not on our mailing list, I encourage you to sign up so that you can keep up to date with what is happening in the network, and you can sign up via the website, or if you want to send me your details in a private chat this morning, I can add you to the list today. To set the scene for this morning, each presenter will have 30 minutes to speak, and this will be followed by some time for questions. You can add your questions into the chat as we go through the presentations, or you can ask the speakers at the end. We'll have a short break after the second speaker, where we can just have a bit of a stretch, and then we aim to finish up at 12 o'clock. So I'd just firstly like to hand over to Dr. Emma Scotter, who will do a karakia, and then I'll introduce our first presenter.
Thank you, Dimpna. Tēnā koutou katoa, everyone. Greetings to you all, and thank you for coming to our final webinar for the year. I hope you're all keeping well at this uncertain time. It's definitely been an interesting year. So I'm just going to open our meeting with a very brief karakia, to acknowledge our participants and you all, and to acknowledge the hard work that all of us in the MND research space have done this year. Whakataka te ho ki te uru, whakataka te ho ki te tonga. Kia mā kina ki uta, kia mā taratara ki tai. E hi ake ana te atapura, he tio, he huka, he hohu, ti he mauri ora. Cease the winds from the west, cease the winds from the south. Let the breeze blow over the land. Let the breeze blow over the ocean. Let the red-tipped dawn come with a sharpened air. A touch of frost, not today. A promise of a glorious day, at least in Auckland. Ngā mihi nui. I hope you enjoy the presentations today. And as Dimpna said, please feel free to engage and ask questions. So I'll now hand back to Dimpna to introduce our first speaker. Thank you.
Thank you, Emma. So first of all, I would like to welcome Dr. Leigh. Leigh is a clinical psychologist who is based in Northwest England. Her research aimed to find out if there was a relationship between levels of stigma and levels of psychological distress experienced by individuals with the diagnosis of motor neuron disease. The study also aimed to find out the strength of this relationship compared to other important factors, such as symptom severity and social support. This study was conducted as part of her doctorate in clinical psychology thesis at Lancaster University. Leigh recruited participants through the New Zealand MND registry, and therefore the results do apply to the New Zealand population. Since qualifying, Leigh has been based in a clinical health psychology department in Liverpool. She's working in the homeless service and has an interest in neuropsychology, psychological interventions for physical health conditions, and how stigma and social factors influence psychologically. We'll discuss her PhD research on motor neuron disease. And I would like to say thank you so much, Natalie, for joining us this morning, or this evening for you, from the UK. I think it's probably after 9 o'clock at night. So thank you so much for taking the time out of your evening to be here this morning with us.
You're very welcome.
I'll just allow you to share your screen.
Okay. So that's all come up for everybody. So yes, thank you very much for that introduction, Dimpna. So I'm Natalie Leigh, I'm a clinical psychologist, and this was the title of my thesis research that was part of my doctorate in clinical psychology. So it was looking at whether a lack of social support and perceived stigma contribute to psychological distress in individuals with motor neuron disease. And I was supervised by Jane Simpson and Fiona Eccles, who helped me with this project. So a bit of an overview. I'm just going to do a bit of background. So what is motor neuron disease and why are social support and stigma important to consider? A bit of rationale, what I did, the results, and what I hope that these can kind of contribute to the field. So motor neuron disease, also referred to as amyotrophic lateral sclerosis, or ALS, and Lou Gehrig disease in the US, is, as I'm sure you're all aware, a life-limiting neurodegenerative condition, which progressively destroys the motor neurons in the brain and spinal cord, which can lead to issues with an individual's ability to control voluntarily their muscle movement, which can lead to paralysis, respiratory failure, and ultimately death. The effects of MND are not limited to the motor functions, however. So behaviour difficulties, cognitive impairment, emotional difficulties, and changes in mood are also common. So because of these challenges that the condition can present, people with a diagnosis of MND are likely to experience psychological distress and decreased well-being as a result. So why is social support important to consider? So when I was doing some of the background research, it's been previously identified that social support can be a significant predictor of depression for people with MND. But that study only used quite a small sample size, with 27 that then reduced to kind of 16 at the final time point. Social support has also been identified as a correlative quality of life for individuals with MND, but those studies kind of use quite restricted measures of social support that only kind of assess the kind of close relationships rather than social broader kind of concept of outside of the household. And then qualitative studies have also identified that social support is an issue of consideration for people with MND. So I think there's a couple of papers there. Mystery and Simpson found that the process of receiving a diagnosis of MND can impact an individual's social engagement, their social status, their identity, and that then affects the individual's kind of relationships with family and friends. And the other research there, Cobb and Hamera, they also noted that social relationships undergo quite a radical change following diagnosis. And therefore it felt kind of important to quantitatively kind of assess the relationship that social support has on people with, in terms of their levels of psychological distress for people with MND. So with stigma, again, why would that be important to look at? So with stigma, it was originally kind of developed by Goffman, and it was the original kind of definition was this undesired differentness. And it's then been further developed to include two kind of components of stigma, whether it's felt or enacted. And felt stigma refers to this feeling of, it's more of a feeling of that their differentness could potentially cause discrimination to occur, whereas the enacted stigma is the actual experience of discrimination. So it can be separated into two kind of components. And through previous research, stigma was identified as a major predictor in terms of quality of life, with the strong felt stigma being a stronger predictor, but that study was focused on quality of life rather than psychological distress, and that study only included 9% of the total number of participants had an MND. So it felt important to kind of study that population separately and independently, rather than through grouped in with the other kind of neuromuscular conditions that were included in that study. Stigma was also identified as an important predictor of psychological distress with other kind of perceivable, with other health conditions that have perceivable physical effects, as epilepsy and Parkinson's disease and MS. So because of the limited research that had been conducted, assessing especially the kind of predictive nature of social support on psychological distress, that's why it felt that it was kind of an area that hadn't really been covered. And there's been no research looking at the predictive nature of stigma on psychological distress either. And most of the kind of treatment and most of the research for MND focuses more on the physical aspects of the condition. So psychological considerations are often overlooked. So I felt that it was important to try and find out more about the role of stigma and social support in order to try and find appropriate interventions to help to try and manage that distress in individuals once they've had a diagnosis. Other researchers also found that improving psychological well-being could also be effective for kind of physical health factors for people with MND as well. As that research found that individuals that had high levels of well-being would have a lower risk of mortality even when the disease severity and length of illness was controlled for. So this study aimed to kind of build on all that past research and address that current gap in the literature. And then hopefully the findings could then highlight the importance of considering these factors when people come into services who've got a diagnosis of MND and might be experiencing distress, because we can then find ways of trying to help them overcome that. So the ethics was gained through the Lancaster University Faculty of Health and Medicine, and then recruitment went through a variety of sources, mainly using social media and through contacting various international support organisations, including the MND Registry, who were brilliant, and MND New Zealand, who were able to share that information and really help with the recruitment. Recruitment did take quite a long time, so I think it was open from October 2017 until April 2019 to try and gain a sufficient sample for the analysis. And luckily I went off on maternity leave at that time, and I was able to kind of keep it open, keep generating more, getting more data in. But we had to recruit internationally due to the kind of low prevalence rates, because I think there's only 5,000 individuals in the UK approximately that have been diagnosed with MND. So because of the kind of international recruitment, that's why we used an online survey method, and we used Qualtrics software to try and collect that, and it was a cross-sectional survey design because of the international recruitment needed. So we used self-report questions for the demographic data, and further clinical information. We then used the self-assessed, self-administered amyotrophic lateral sclerosis functional rating scale, the SAALFS-RSR. We also used the social support measure was the multi-dimensional scale of perceived social support. Stigma was assessed using the stigma scale for chronic illness, and psychological distress was measured using the DAS-21. The analysis, so there's two types of analysis. So originally for my thesis, we used the correlational analyses and hierarchical block regression. But then I will talk about the further analysis that was done a little bit later on for publication. So the analysis was the correlations and the hierarchical block regression models. We recruited 77 participants. The majority of the sample were male with a mean age of 59, and the most common nationality was New Zealand. That was where recruitment was most successful. And then the average time since symptom onset was kind of 3.5 years, and time since diagnosis was 2.4 years. We used non-parametric correlation analysis, the Spearman's row, as some of the data wasn't normally distributed. And it was a theoretically driven model based on past research. So for the correlations, none of the demographic or clinical variables produced a statistically significant correlation between the outcome variables, which were the stress, anxiety and depression. So social support was negatively correlated with all of the DAS scales, indicating that less social support is associated with higher levels of stress, anxiety and depression. And then stigma was positively correlated with all of the scales, suggesting that higher levels of stigma are associated with higher levels of stress, anxiety and depression. And the felt stigma had the stronger correlation than the enacted. So with the regression models, this was, with it being kind of theoretically driven, we entered them in order of demographic and clinical variables were entered first. Then we added in the social support and then the stigma. And that's because stigma had never been kind of researched before, whereas social support had some kind of research previously conducted. So with the stress model, the demographic and clinical variables made up 1% of the variance. Then social support added a further 16%. That then increased by a further 25% to a total model of 41% variance after stigma was entered, and the overall model was significant. And social support was identified as a statistically significant predictor for stress at step 3 of the model, but then when stigma entered the model at step 4, it was no longer statistically significant. And at step 4, only the self or felt subscale of stigma was a significant independent predictor of stress. In the anxiety model, demographic and clinical variables again accounted for less than 1%. Social support added 17.5% of the variance. And then the two stigma scales added a further 14.5% to a total model variance of 31%, which was significant. And social support was identified as a significant predictor for anxiety at step 3, and it also remained statistically significant at step 4 alongside the felt stigma subscale. And then in the depression model, again, demographics and clinical variables were less than 1%. Social support added a further 22% of the variance. And then when the stigma scales were added, they added a further 30% of the variance. So the total model was 52%, and that was significant. Social support was identified as a statistically significant predictor of depression at step 3 and just about remained a statistically significant independent predictor at step 4 alongside the felt subscale of stigma. So overall, the results suggested that individuals that have higher levels of perceived social support and lower levels of stigma have lower levels of psychological distress, and conversely, so people who have lower levels of social support and higher levels of stigma have higher levels of psychological distress. So there were some strengths in the characteristics of the sample were quite similar to characteristics kind of identified in the MND population in terms of kind of the prevalence rates, and I think it was the gender was very similar, time since symptom onset, and yeah, sex as well, male, female, were very similar. In terms of limitations, it was cross-sectional design, so just one single standalone time point. It was still quite a small sample size, even though it took a long time to recruit that many. It was still small overall. There were some recruitment issues, particularly trying to access participants in the US. I think there was only 2 US participants in total. And it only included people who could speak English well enough to complete the survey, so the results might not be generalisable. And interestingly as well, that the levels of stigma and the levels of stress, anxiety and depression were quite low in the sample. So therefore, if it was a sample of people with higher levels of distress, we're not sure if the results would be the same. In terms of the kind of clinical implications for stigma, previous kind of systematic reviews have identified that the most effective interventions are aimed at the kind of interpersonal and community levels. So looking at, broadening that out rather than just the individual themselves. And effective interventions aimed at targeting stigma have been found previously for other conditions such as HIV and mental health diagnosis. And they include education, counselling, cognitive behavioural therapy, drama therapy and social support groups. So they're potential interventions that could be then applied within people who have had diagnosis of MND to try and alleviate some of that stigma. Research also suggests that mindfulness is positively associated with stigma resistance. So that's people with psychiatric diagnoses, but it does suggest that mindfulness-based interventions might be beneficial in trying to reduce stigma or increase an individual's kind of resistance to the stigma that they're experiencing. There's also the concept of psycho-emotional disableism that could be useful to kind of might be a useful conceptual framework to use for people to try and understand how society can impose limitations and barriers to an individual. So this kind of is a framework that looks at whether an individual is actually kind of, is somebody disabled, or is it the way in which society and how we structure things actually makes people not less able to do things. So actually using that kind of framework attempts to try and change things more at a community and a larger structural level, which could help with the kind of a stigma at a broader range rather than just aimed at the individual. And in terms of social support, research has identified interventions that have been helpful for people to reduce levels of depression in mixed samples. And so that could be peer support groups, could also be trying to use interventions that are aimed at improving relationships with family and friends, developing social networks, whether that's through community activities, gym classes, kind of music groups, or more formal support options, so community support provision and befriender services. So by being able to improve people's levels of social support, that can hopefully help to reduce some of the psychological distress that people experience. So leading on from this research, it felt that more research would be beneficial to try and look at and explore that relationship between these variables further, maybe by testing out the kind of the stress buffering model that would suggest that social support could act as a buffer between MND related stress and psychological distress. So if you've got the enacted stigma as being the MND related stress, whether social support could then try and buffer that and reduce the impact of any kind of stigma that has on creating the psychological distress. So it'd be beneficial to try and explore that further to determine that relationship between the variables. So after completing the research for my thesis, it was submitted to the British Journal of Health Psychology, but they wanted amendments to the analysis that was used. So we changed the analysis from a hierarchical regression model and looked at moderation and mediation analyses. So we reanalyzed the data, and it was hypothesized that social support would moderate the relationship between MND-related stress, which we operationalised as either enacted stigma or physical functioning, and the psychological distress. And we also hypothesized that felt stigma would significantly mediate the relationship between MND-related stress and psychological distress. So after doing all the extra analysis, the moderation analysis wasn't significant, but that's likely due to the sample size, because when we did a power calculation, it suggested that we needed 316 participants to detect the large effect size, which we weren't near. And then with the mediation analyses, that identified felt stigma as a significant mediator in the relationship between enacted stigma and psychological distress. And there was also a direct relationship between enacted stigma and stress. So these findings are consistent with the theoretical model of self-stigma, which suggests that public attitudes, so the enacted stigma, can produce personal responses that then create this self-stigmatization, which then leads to negative consequences for the individual in terms of being having psychological distress. But the direct path between enacted stigma and stress also remains significant after the mediation analysis, and that suggested that the actual experience of discrimination also relates directly to stress levels, independent of this kind of internalization process of the negative stereotypes. That's the that's the reference for the publication, and I think just lots of references. And thank you very much for listening. Does anyone have any questions or anything they'd like to ask?
I have a question for you, Natalie. I'm really interested to hear that New Zealanders were the most frequent participant for you. 18 of your 77 were New Zealanders. Is that because our New Zealand patient registry is wonderful, which it is, or is there some particular signal that comes out of the New Zealand cohort? Are they particularly motivated to participate in the study because they have higher levels of stigma, or are they under more psychological distress?
So I don't think there was any patterns identified in terms of having higher levels of psychological distress. I think it was one, because you have a brilliant MND registry, you're fantastic at kind of collaborating with research and sharing agent. But whether there could be something related to kind of community involvement that might be different in New Zealand than in some other kind of aspects in different countries, haven't explored that further, but that did occur, perhaps, the sense of community and the sense of being able to kind of connect with others that might be stronger in New Zealand than, say, in some other European countries or in the US. That would be another topic to explore. But yeah, I think it is just because you've been brilliant at sharing information as well and getting the word out there.
Thank you.
Yeah, I was quite interested as well in terms of with the recruitment and how difficult it was for you. And I'm just wondering, do you think maybe an element of that might be that maybe people didn't have that support to be able to maybe complete the forms that were online, or anything like that? Would it be an indication that maybe some people that didn't participate was because they didn't have the support to be able to participate?
Yes, definitely. And I think that might have, so there was something that we touched on about it. It also felt that the population was quite younger in the sample that we had. So it was more leaning more towards younger people and people that had more access possibly to complete an online survey and that might have had the support in order to do that. Whereas people who obviously didn't have that support available to them and might not have had that social kind of support wouldn't have been able to necessarily access the survey. So yeah, I do think that there was an element of that within it.
I have another question as well, and I don't know if you looked at this, but if you did, was there any difference in with the social support and stigma and psychological distress for people who might have been at an earlier stage of their diagnosis versus people who maybe had MND for a couple of years?
It isn't something that we kind of explored more, but it is something I have thought about because we had an expert by experience that went through all the kind of measures with me to begin with and helped me kind of structure this, and that was a family member of somebody with MND. And they shared with me that actually following diagnosis, the social support did kind of shrink over time. And actually people who were diagnosed earlier on might have had access to more social support than those who had been kind of living with the condition longer. So it is something that had been kind of there at the back of my mind, but it just wasn't something that we kind of analysed through this research.
Does anybody have any questions for Natalie? I'm just interested, Natalie, with the, and I don't know again if this is something you looked at, but people who might have been linked in with like a motor neuron disease kind of association or patient support group, if that was asked, and again, whether or not there was kind of some social supports through that. Again,
so it isn't something we kind of looked at. It would be something that would be kind of interesting to know more about. That wasn't one of the questions that was asked, so I wouldn't be able to even kind of reanalyze it and check. But I think everybody, well, no, I can't say that. I was going to say the people who did access the survey, a lot of the people that kind of shared the information were through kind of MND support groups and support networks. So for the MND New Zealand Association, and the same in Scotland, England, a lot of the recruitment and advertisement went through those services. So I assume some of the people were in contact with those services to have got through to complete the survey. But then again, it might have been people that had shared the information online through social media. So yeah, it would be interesting to know. With hindsight, should have included those questions to find that out.
Okay.
We do have a number of our MND support workers and other people in leadership positions in MND NZ on the webinar, so they're probably very pleased to hear that their support enabled participation of more New Zealanders than anyone else in the study.
Yes, definitely, and thank you so much to everybody who did contribute to sharing that information. It was absolutely fantastic. Like I say, the majority of the participants were from New Zealand, so the help you provided with recruitment was astounding, and really, really grateful for everything that you were able to do to help with that.
No problem at all. Thank you, Natalie.
Thank you very much. Well, if anyone does have any other questions, you've got my email as well, haven't you? So feel free to kind of send it on if anyone thinks of anything afterwards.
Yeah, exactly. Feel free to email me and I can pass it on to Natalie. And Natalie has kindly also shared her slides and her publications. So when I send a copy of the recording out to everyone, I will include them in it as well. Thank you, Natalie.
Thank you very much.
Thank you.
Erin.
Okay, so next up I'd like to welcome Dr. Alan Stanley. Alan is a neurologist that is working in Hawke's Bay, DHB. Alan completed his medical and neurological training in Cape Town, South Africa, and moved to New Zealand in 2018. Alan is a member of the New Zealand MND Clinical Working Group since 2019 and became co-chair in November 2020. Today, Alan will discuss a study that's looking at the costs associated with MND in New Zealand, and he's working on this with a group of researchers. And he will also discuss the New Zealand guidelines for the assessment and management of MND that has recently been developed by the Clinical Working Group. I'll welcome Alan.
Get myself unmuted. Okay. Hi everybody. Let me just move things around to get the right screens shared. I'm going to turn things around a little, just so that because I'm actually presenting two sort of pieces of work. So the one is the guidelines, and the other is a pending study of the costs associated with New Zealand. That's actually just going through final ethics. So I don't yet have any data on that, I'm afraid. But I'll present the protocol and our thought processes on that. The other sort of disclaimer is I am involved in these, but presenting on behalf of everyone who's done a lot of the preparatory work and getting these studies organized. I hope you can see my screen. Is that all right? Yep, good to get a thumbs up. Okay, so some of you have seen this talk before, but the one of the important projects we've been working on is the guidelines, which we've revised to call best clinical practice for MND. And why do we need a best practice document? And really, as you all know, MND is a condition with rapidly changing needs across multiple clinical domains and specialities. And so care coordination and multidisciplinary care is really the gold standard of treatment, particularly because we don't yet have any truly effective disease-modifying therapies. New Zealand has many areas that are remote with difficulty accessing a full range of therapies, and some of the smaller areas don't have the depth of clinical experience available in larger centres. And so guidance is particularly helpful in directing people towards important aspects of care. And so really we felt that improved coordination and planning is the key to successful therapy. And this process really, again, came out of the MND New Zealand structure, and they did a community service in 2018. There was a follow-up survey to clinicians shortly after that, and that led to a hui of clinicians involved in MND care, which some of you will have been at. And that led to a very important multi-pronged initiative, improving care, improving lives, which I'll outline the structure of in a minute. And the best practice recommendations really forms part of that. So that whole process identified a number of discrepancies, and a lot of that's about standardization and coordination. So within between different DHBs, within specialist groups, within clinical departments, there are differences in care. The knowledge about MND and its management varies a lot across the country, and in general, the referral pathways can be a bit fragmented, and there's also a lack of translation of international research into actual clinical care. And so for all of those reasons, a document would be helpful. So this is the outline of the Improving Care, Improving Lives initiative with feedback from various people, including the MND community. The information and guidelines component is what I'll be talking about today. There's a parallel project within MND New Zealand for improving information to patient and carers, working with the health authorities, and obviously that's kind of thrown a bit of a spanner in the works of how exactly to phrase some of these things, because we went from DHBs to overarching authorities, and that in itself is going to change some of the pathways. We're working with Health NZ to try and have this embedded within their workflow. The development of the clinical network of MND experts is sort of a out of the WHOI, we had a group of volunteers to set up the clinicians working group, and our first project really has been developing the guidelines, but it's hoped that this group will continue and serve as a expert panel to provide advice to people struggling with difficult clinical problems throughout the country, and then working with the ministry on more practical advocacy issues, which is also an ongoing project. So the clinical working group, as I said, came out of the WHOI, and the structure of how we've been working is we had monthly online meetings to develop the recommendations, which and every month we would have a draft chapter prepared, which was largely Claire Riley's excellent work, and we would then discuss and review all the recommendations. We would review the changes from the previous month and accept them. And the overall structure was drawn from international guidelines, mainly UK and Canada, adapted to our own experience and to try and tailor it to work well within New Zealand. Maori consultation, we were very fortunate to have Graham Cameron, who's subsequently been appointed as the Putukanga at the Bay of Plenty, who reviewed the first draft and provided some initial input, and then the final draft was reviewed by Melissa Carey, who's a nurse researcher in Auckland, and she has a particular interest in cultural safety and clinical practice and end-of-life care, and she provided some very useful input. To be honest, it's been quite an interesting experience trying to make a guideline truly cultural sensitive. There are issues around how exactly you structure a diagnosis, for example, where you should, in a Maori-centric view, take in the information from the family about level of function and social well-being, which is quite difficult to dovetail on top of a sort of Western diagnostic process where we're much more focused on a sort of individual clinical history and clinical exam. So I think this is probably an area that needs some ongoing work, but I think we've come up with an appropriately sensitive document, although there are areas for improvement. We also then, with the final guideline draft, submitted to various professional societies to get formal endorsement. And we're almost through this process. I need to review some final changes, and I'm holding things up a little bit, but we're about to send things back to the Thoracic Society for their final approval. And I presented this at the Neurological Association meeting about a month ago and got endorsement from them. The palliative care group has been involved, and we felt that rather than getting, it's a bit tricky, how many organizations you approach to endorse a document, and we got some feedback from individual GPs rather than getting a formal societal level endorsement, just to try and make sure that it was reasonably workable at a GP level, that it would be a helpful document. And then we are also going to be submitting it to the Maori Doctors Association to get a final approval on the cultural sensitivity and appropriateness of the document. So it's it's quite a big document to talk through, and I'm really just presenting a summary of the recommendations, but this is the outline of the chapter structure and the areas we cover. And we've tried to cover I think all the main points. One of the important barriers to care is actually getting a diagnosis, because you need the label before you can access appropriate care. And so we really tried to drive awareness of the condition, and that I think is going to need a lot of ongoing work to keep the diagnosis in sort of GP's radar of thought. But the main message is that you should think of MND if there's any progressive weakness in the absence of sensory signs. We wanted GPs to be a bit less coy about mentioning it in referrals, because the other barrier is once someone presents to the GP, then the referral goes through to the specialist. But if the wording is a bit veiled, it's sometimes difficult to know what the true suspicion is. And so if the diagnosis is suspected, we want it highlighted, because if it's specifically stated, it's easier to triage that referral as urgent. And if there are particularly worrying clinical signs like respiratory difficulty or swallowing difficulty, that they should we've encouraged people to talk directly to the specialist involved to try and get them prioritized. And we also have highlighted the importance of the GP providing appropriate emotional support during this tricky phase. We've recommended the brief screening tool, the red flags for MND, which has been around for several years and is quite familiar and easy to use. And in terms of specialist diagnosis, we didn't want to be too prescriptive, but we recommended using the Gold Coast diagnostic criteria, which are a bit more sensitive, slightly less specific, but I think they're a more appropriate clinical criteria because they're less restrictive than criteria used for research. And the previous criteria will be familiar to you, but this is just to point out that its sensitivity is a bit higher than the others, but the specificity is slightly lower. Communicating the diagnosis once we've gone through the diagnostic process is also important, and hearing the impact of how this is delivered on the anxiety and depression in the previous talk was interesting. And we recommend that a senior clinician give the diagnosis, preferably the neurologist, or in areas where there isn't a neurologist, by the lead specialist in the MDT. We recommend that the diagnosis should be given in a staged fashion, and this would typically in clinical practice be an initial clinical visit, some suggestions of diagnostic possibilities, often an EMG, and then a subsequent visit to finalize the diagnosis. We've encouraged that an appropriate support person is present to provide emotional support. We also have outlined some of the topics that should be covered over the first few visits, and there's a lot to cover, but essentially the main points are progression and prognosis, treatment, particularly emphasizing the importance of the MDT, focusing on disease-specific treatments, of which riluzole is the only one available in New Zealand, practically speaking, the importance of nutrition, feeding options, and respiratory support, and then treatment, that highlighting that treatment is available for specific symptoms as the need arises. I think often when people are given a diagnosis like motor neuron disease, the absence of a disease-modifying therapy is felt to be there's no care here, but actually there is care, and that care does make a difference. We also have briefly touched on genetic testing, which we've recommended for anyone with a family history or young onset disease. There's an ongoing or a project in development to formalize clinical testing, which I think will be very helpful in getting a better structure and recommendation about exactly what we should test for and when, which will be separate to this document. We also feel it's important to talk about research opportunities, and I think apart from the registry being very helpful in facilitating international research, I think our MND community are particularly engaged, and we seem to get very good feedback and response rates on surveys and research. And I think our community really is very keen to be involved in research, which is it's important for us to try and link people in as much as possible. And we feel it's also important to touch on unproven treatments and the need for caution in their use, because obviously with a disease like this, there's a lot of quackery, and people are vulnerable, and you need to balance directing people appropriately towards hopeful therapies, but avoid the risks and expense that comes with a lot of these therapies. And obviously where to find more information and support, and we largely reference the MND New Zealand support services. We advocate multidisciplinary care as a cornerstone of treatment, and we're hoping, as I mentioned earlier, that the clinical network is going to continue as in lieu of a physical centre of excellence. We have a virtual centre of excellence. So we have the virtual MDT of the Clinical Working Group that can provide expert advice to individuals in areas that may be less experienced. We want every health region, and this is one of the things that's changed with the restructure, to have an MND MDT at a local level, ideally every hospital, and that every region should also have a care coordinator. Now, Canterbury is the only one that have had this formally as a role, and they've just transitioned out of their first person to the second person, and they are, I think, very importantly doing a research project to demonstrate how valuable that is. And I think that's going to be a really useful advocacy tool in the future, information from that research. Really, respiratory nutritional management and communication, the key message is plan ahead and do things early. And we recommend baseline lung function testing, early referral to respiratory and speech therapy, and early discussions about PEG. And often, obviously, these are quite confronting discussions to have with people early in the disease, but it's really critical, particularly with things like voice banking, that this starts ahead of time, because once your voice starts to deteriorate, the quality may be too poor for that banking, for example. We want to obviously closely follow respiratory function, because appropriate provision of NIV is one of the key differences in good care. And so monitoring these factors and discussing them ahead of time allows the intervention to happen at the most appropriate time. I spoke briefly about communication, and this is obviously one of the areas that has a significant psychological impact, and so discussing this ahead of time to facilitate better communication in the advanced stages of the diseases is very important. And obviously it also reduces caregiver burden. Equipment and adaptations, we want clinicians in the allied medical staff particularly to have a good knowledge of what equipment is needed, how MND can present, and how the decision making around the choices and timing can impact on care. And this is one of our main areas of advocacy with the Ministry of Health at the moment, because the pathway is actually very fragmented, and it doesn't really, the disability pathway as a whole doesn't suit a disease where you're having rapid development of changing and progressive disability. It's quite good for static disability where the timing is not too critical, but the urgent pathway is really poor. And so we do seem to be getting some traction in smoothing this out and getting appropriate pathways, which will obviously help this, but still local knowledge of how to access those pathways is also key, and we hope that the guidelines helps with this. Planning for end-of-life care is another obviously important aspect, and that we think that introducing the palliative team in the middle to late, middle stages rather than the very early stages is important. That every member of the MDT is prepared to answer these questions, because you might see the OT in between your neurology appointments, and actually the OT's skills in being able to discuss some of these issues and direct people in the correct pathway are important and helpful. And we encourage people to have advanced care planning discussions as the person feels ready for them. Obviously, they may not be in the right headspace for this, but constantly asking those kinds of questions and getting a plan in place will also improve end-of-life care. So our hope for the future with this project is really that we want every person with MND to have the best possible care and be able to access coordinated, good quality care urgently and at the appropriate time. We, as I mentioned, are engaging with the Ministry of Health, although the final document hasn't been finalized. We're moving ahead with that. And initially we're discussing the equipment access and prioritization. We're trying to discuss the appointment of care coordinators, although there's a little bit of vagueness around that, but hopefully some more research will be helpful. And we've managed to support a parallel process of access to respiratory support. So the Thoracic Society has already engaged and set up a working group, and we've got representation on that group and are advocating for our community and access. And we've tried to encourage them to keep their terms of reference quite broad, because respiratory support obviously includes staffing and in MND things like cough assist devices, which don't necessarily apply to sleep apnea and BiPAP machines for other conditions. And we'd like to keep auditing where our gaps are. So we want people to feed back to us how things are working and allow us to, this provides us with information that improves our advocacy with the ministry, and we would encourage regular local clinical audits. And this is just the members of the group. That's been a large project with a lot of people, and everyone's been very generous with their time in contributing to these meetings, and it's been a hugely educational and inspirational process. So that's the end of this little bit. So maybe we'll pause for questions about this section. Oh, sorry, now I'm stop sharing. There we go. Okay.
Alan, can I ask, what has the feedback from GPs been like? Are they welcoming the idea of change? You know, what, and also the patient community, carers and whānau, what are people saying about this document? What feedback have you had?
Yeah, so GPs have generally been quite enthusiastic. I mean, I think they find neurology in general a bit of a forbidding kind of clinical area, and so more guidance is helpful. It is tricky to make a broad guideline kind of punchy and really user friendly, and I think we've done a fair job at that, and we're planning to summarize this for publication in the New Zealand Medical Journal, which I think will be helpful, because then there'll be a summary document that'll link people, and I think that'll be probably more useful. But I think the feedback we've had from GPs is that it seems useful and that it's an important thing to know about. We haven't yet got any whānau or community feedback really, because it hasn't been published. It's been a predominantly clinical review at the moment. But we anticipate it'll be well received, because this, out of the initial community survey, was one of the main sort of shortcomings, is that we didn't have any clinical guidance. So people felt that their care was fragmentary, and they didn't have anything to reference the care they were getting on, or sort of discuss with their doctors about, should I be getting this or not. So I think having local guidance will probably be well received. At least I hope.
Alan, how do you plan to roll this out once it's finalised and published?
Yeah, so as I mentioned, the summary guideline will hopefully be published in the medical journal, obviously subject to them accepting it, but I presume they will. And then we will be, the full document and summary will be on the MND New Zealand website as a sort of main port of call. And yeah, that would be the sort of two main points, and I guess it'll be included in our clinical communications with the GP groups. We're trying also to. There's a bit of software called Clinical Pathways, which GPs access in many DHBs. I think Hawke's Bay were the last one to get access to that, and there is an MND pathway within that, and we are looking at improving that and trying to get. Because obviously you have to suspect it before you access that pathway, and that I think is the key difficulty with all of this, is that we need people in the community, clinicians, GPs, speech therapists, ENTs, to be aware and thinking of MND, and I think that is a harder problem to address just with a guideline, because it's really about trying to raise it as an important issue with a number of different groups, and so we'll need some broad community thought on how best to do that going forward, because it is something that needs momentum and needs to keep being refreshed, and as new people come in, but this hopefully is a good start.
Just wondering, would you be considering like notifying like the allied health kind of associations like EOT board, speech and language, and all of them to help get it into those networks?
Yep, that's a good point. Actually, that reminds me, I should have said that we do anticipate that members of the clinical working group will present this to their local meetings and professional bodies. So that we're wondering whether we should be doing that already, but we thought probably we should get final approval and endorsement from all the professional bodies before doing that. So that will go ahead. So hopefully, be presented at physio, OT, speech conferences in the coming months and years. Yeah.
No, that's great.
Ellen, the invisible me just wants to say a huge thank you to you and Claire and all the team. For those of us working with people at home, this will just make such a huge difference. And in particular, your work on the diagnosis and communicating the diagnosis is going to make such a huge difference for so many of the clients to come in the future. So thank you. It's been a huge amount of work, but really so valuable.
Thanks for the feedback, Jane. That's very kind of you. Yeah, it has. We hope so. I mean, I hope that it'll improve, and this is the first draft. It'll need revision in the future, and as we find areas that don't work so well, we'll try and improve them. So we're planning to review it every 3 years, and so the support worker feedback has been very useful in addressing a number of issues and highlighting gaps in care across the country. So you and your team's input has also helped to inform the development. So thank you again. Thank you. Back to you. Right. If there are no questions there, I just briefly have a few slides on our next project. Let me try and get this. There we go. Okay, so as I mentioned, this bit of work hasn't yet happened, but it's about to start. So we anticipate we'll be sending out the survey in January. We decided after a few delays to wait until after the holiday season before getting people to fill in a rather lengthy questionnaire. But this bit of work is going to be looking at the costs associated with motor neuron disease in New Zealand, and why study costs. I mean, some of it is obvious, but again, referencing that community survey that I spoke about in the guidelines, that 40% of people with motor neuron disease highlighted that they had unmet practical needs, and 70% of carers had unmet practical needs. And these weren't costed or measured in that survey, but I think it's kind of obvious that MND is probably an expensive disease, and there is some there is some research on this. There was a study in Australia a few years ago that estimated the annual cost at $2.4 billion. I think the individual annual cost is just over $1 million a person, which is quite significant. And that's one of the few studies that assesses sort of total cost, because it is tricky to access those costs reliably. And there are a number of different things that contribute to the costs: the medical expenses, the equipment, the care costs, and very importantly, the loss of income when younger people are affected. And not only for the person with the illness, but their partner and support network also bear significant economic burdens. And we obviously particularly want New Zealand specific data, because we want to know how things stand in New Zealand. And this is going to be, we hope, an important bit of data to help advocate for change and better resourcing in areas where things are deficient. So the aim is to estimate from a societal perspective, and that's government and individual, so as comprehensive a cost as we can get, the 1 year direct health care and indirect productivity loss, including informal care of MND per capita in Aotearoa, New Zealand. And we're going to do that for 2021. So the methodology is we've developed a clinical questionnaire, which has had a lot of back and forth discussion. And we're trying to get clinical symptoms which are really based on the ALS-FRS to get an idea of clinical stage, because we think that the cost will vary depending on where you are in your disease course, and that early on there'll be a lot of diagnostic costs, care access costs, and that later on you'll have increasing economic impacts from loss of income and increasing use of equipment and services. So the questionnaire looks at 6-month recall, except for diagnosis where that was longer ago than 6 months, of what tests and procedures you've had in the last 6 months, what equipment you've been using, what appointments you have, and what hours of income you have lost. We have, because of the privacy issues, we've divided consent to try and access the registry and MOH. So you don't have to do that part of it, but we've encouraged people to do that because we wanted some way to objectively assess whether the reported costs were reasonably accurate. And so we'll be using the MND registry data for some of those costs, and the Ministry of Health records for things like admissions and appointment usages and that sort of thing. And so hopefully that'll give us not only the self-reported costs, but also an objective measure of that these were reasonably accurate reported usages. Now, the sort of economic analysis is where I quickly come a little unstuck in how much I grasp the nuances. But essentially, we're trying as much as possible to analyze all of the costs involved. So we decided after some discussion that we would, for income, we would use assume a median income, assuming we would have patients across the spectrum of illness. Partly that's because people we feel it would be reticent to necessarily disclose their exact income, and so it would probably be easier to just assume that overall we'll have a median income. And so it's cost of hours lost for the person and their primary caregiver. We asked them to estimate out-of-pockets costs, and that'll be their stated costs for not covered by state care. The formal and informal costs we're getting, if you have a carer who's covered by services not paid for by you, there'll be a cost identified with that. And then informal care costs, we're going to basically use that same cost because it's the replacement cost of if you couldn't get this care from your family, someone else would have to provide it. And therapists and doctor costs we're using from the DHB and MOH databases and standard costs. Hospital costs, there's an interesting, so every admission gets something called a weighted discharge value depending on how sick you were thought to be on the basis of where you were, what your discharge diagnostic coding is. And so we're using those costs, which are a summary of All the clinicians, allied health involved in your care, lab costs, it's sort of an average cost for that illness. And that varies a little bit depending on whether you're in ICU or the general ward, but that you get a daily cost of your level of care, which for ward care, interestingly, is about $5,500 a day, which is quite a lot, sort of more than I might have thought. The prevalence is one area that's a bit tricky, and this is, I guess, a good time to put in a plug for an upcoming future study. We're in the planning stages of trying to get a formal prevalence study done, and we're hoping to have a master's student, and there will be some funding for that. So if you have anyone who has an interest in epidemiology and would be interested in being involved in a prevalence study, I think that would be another key piece of data. But for now, we're using best available data, which is, we presume that the MND NZ client database captures most patients in New Zealand. We acknowledge not all, but that roughly works out to 7.7 cases per 100,000, which does seem to match up with the international prevalence. And so it seems like a reasonable estimate. We're going to try and do a mortality data cross-check. So what the assumption there will be that if we have all patients within the MND NZ clinical cohort, and we would have a certain number of deaths in that group, and if our death rate for the year matches up with Ministry of Health mortality statistics, then we probably have most patients. It's kind of a bit of an odd one, but I think it's after a lot of back and forth and trying to work out how best we could get another estimate of that we have the right numbers. We felt that was probably going to be the most useful. The outcomes, as mentioned, are really cost to society. We're trying to estimate uncovered costs. So what are the economic costs borne by the individual and their family, because that's obviously a key piece of information. And we want to identify the gaps in funding and support to try and improve that support for people. So that's basically what we're planning to do. Hopefully we're back to the other screen now. So yeah, that's still upcoming, and we may be able to give you another talk next year about what we found. But I think, yeah, particularly with respect to the prevalence study, please do advertise that to your networks.
Yeah, and I just want to say, actually, that prevalence study, the link for it, if you do want to share it with others, is available on the MND network website under opportunities for researchers. So if there is anyone you want to share it with, you can direct them there. Yeah. Thank you, Alan. That sounds really interesting. Just in relation to hospital admission costs, I can't believe it either, the price of a ward stay, but will that be coming mainly from looking through the medical records to find out people's admissions?
Yeah, so I mean, people will report their admissions, but hopefully we're hoping the Ministry of Health data should capture all of those. And so those that we're kind of hoping everyone will give us permission to access those records. And I think that the community really is very engaged, and I anticipate that everyone will probably give us access to that. So we've asked for self-reported hospital admissions, and we may, without the formal diagnostic code, to use the appropriate WEIS estimate, have to estimate that. But mainly we're going to be getting ministry data of what that cost was and how many admissions they had. Yeah.
Does anybody else have any questions that you just want to ask Alan about that upcoming study?
Good.
Okay. So what we'll do is we'll just take a very quick 5-minute stretch, and then we'll come back for our last presenter. So we'll aim to be back just after 11:20. Thanks, everyone.
Thanks. Thanks.
Sorry, it was quite a short break, but just in the interest of time, we'll keep going. Finally, I'd like to introduce Dr. Mandy Wilkinson and Justin Jordan, who are both part of a group of researchers from the Canterbury Respiratory Research Group at Christchurch Hospital and the University of Otago in Christchurch. And they're examining the impact of having an MND clinical nurse specialist. There is two parts to this study, a qualitative and a quantitative. And today, Dr. Mandy Wilkinson will discuss the qualitative aspect of the project and Justin Jordan will discuss the quantitative part. Mandy is a qualified nurse and is working at the University of Otago, Christchurch as a lecturer in the Centre for Postgraduate Nursing Studies and as a research fellow for the School of Physiotherapy. Mandy is passionate about working together with people with long-term conditions and their families and feels privileged to hear their stories. Mandy enjoys contributing to research that brings about positive health service system change. Justin is a fourth-year medical student undertaking the quantitative aspects of this research as part of a summer studentship through the University of Otago, Christchurch. Before studying medicine, Justin completed a Bachelor of Science, majoring in neuroscience. Throughout his studies, he has had a particular interest in neurological conditions such as motor neuron disease, and so was very keen to be involved with this important research. This is his first experience undertaking formal research, and he is looking forward to helping collate local MND data and hopes to show the benefits patients have received by having a designated MND clinical nurse specialist in Canterbury. Welcome, Mandy and Justin.
Thanks, Dipna. Thank you for the introduction. George is going to drive the PowerPoint. Yeah, can everybody see that? Yeah, cool. Right. Tēnā koutou katoa, ko tūbām te maunga, ko tef te awa, engare I tipu ake au ki Gerdif Kumri, I te tau 1972, I haere mai au ki Aotearoa, ko Mandy Wilkinson, toko ingoa no reira, tēnā koutou katoa. So welcome and thank you for the opportunity to come and share the project which we're undertaking in a partnership with the Motor Neuron Disease Association, Canterbury DHB and the Centre for Postgrad Nursing Studies. And we'd like to thank the Motor Neuron Disease Association who are funding the project. As Dipna said, I'm Mandy Wilkinson and I'm working as a lecturer and a health researcher at those two different departments at the University of Otago. And I'd also like to introduce Justin, a research colleague of this project.
So, kia ora, I'm Justin. You've kind of all just heard my intro, so I'll skip that part. But yeah, I'm doing the quant aspect, which I'll talk about in a little bit.
So, some background to the project. As Alan outlined, there's been research completed in the New Zealand space. There was a research undertaken in 2006 in Canterbury, and that showed a rising incidence of motor neuron disease with a median survival of around 17.6 months from diagnosis. Since then, there have been changes in how people with MND have been cared for, and this includes the new medicines that Alan mentioned and also the appointment of a dedicated care worker. These changes aligned the service in Canterbury with international best practice, the NICE guideline, and that has been shown to improve survival in MND in other places. And as Alan talked about briefly, there's the, in 2018, there was the MND New Zealand Commission National Community Survey to identify the care and support needs of people with MND and their family and carers, as well as the access to health services and information and preferred areas of research. And in response to the questions about research and the health services developing clinical pathways, so all New Zealanders with MND are given consistent, high quality care. What that was considered to be the most important research area. And people with MND also wanted to see more advocacy at a national level to improve MND healthcare provision. And Alan also mentioned the follow-up survey that was sent to the 50 clinicians that indicated while they used a multidisciplinary team approach, the nature of this varied significantly between the DHBs, and only the Canterbury District Health Board had a single point of contact, the MND Clinical Nurse Specialist, and held regular specialised MND clinics. So MND New Zealand has responded to all the information that's been gathered from the surveys and the subsequent hui, and they've developed the clinical working guidelines that Alan was talking about. And a key recommendation that Alan highlighted, and one that we are pursuing here, is the single point of access in each region for people who are diagnosed with MND.
So just a brief introduction to the team involved with this research. So on the bottom right there of your screen is Dr. Rachel Wiseman, and she's a respiratory and palliative care physician involved with the MND clinic in Christchurch, who'll provide some clinical oversight of the project, which will include connecting research team members with the MND community and other clinical staff. Just above her is Dr. Michael Epton, a respiratory physician here, and part of the director of the Canterbury Respiratory Research Group at Christchurch Hospital. He'll provide some oversight of the research process and assist with data analysis. In the bottom left is Dr. Melina Storer, the research manager of the Canterbury Respiratory Research Group. She's responsible for kind of the operational aspects of the research, supervising me as I do my work, and supporting research tasks and ensuring the final outcomes, that kind of thing. In the top, in the smallest circle, is Dr. Mandy Wilkinson, who you've met. She's responsible for the qualitative aspects of this project, including the ethics process, planning and execution of any interviews, data analysis, and draft publication / report writing, which she'll talk about very shortly. And in the middle there is myself doing the quant aspect, which I'll talk to soon.
So recent international literature exploring the experience of being diagnosed with MND reiterates the work that's been undertaken by MND that suggests that timely diagnosis reduces the uncertainty and underlines the importance of early referral to disease-specific support services. And then there's been a recent review of qualitative studies which again reinforces that early effective communication with a single point of contact can help anticipate and plan intervention options to manage deterioration and reduce uncertainty for people diagnosed with MND. As far as I can find, there's been no exploration of the client experience of the clinical nurse specialist role anywhere that I could find, and the multidisciplinary MND clinic service. So it's therefore very timely to explore people's perceptions of this service. So the overall purpose of this study is to assess the impact of the model of care that's been embedded in the service delivery in Canterbury for people with MND. And as we've said, there's a couple of phases. There's a qualitative phase and a quantitative phase. And we've got a number of aims. And firstly is to discuss with people with MND their experience of the clinical nurse specialist role and the multidisciplinary team clinic and how that has affected their care. And secondly, we wish to build on prior published work through undertaking some quantitative analysis of existing data and to investigate before and after the implementation of the clinical nurse specialist role in multidisciplinary clinic, some changes in a number of key indicators. So my role in this project is planning and execution of the interview phase of the study, and that's involved getting ethical approval for this part of the project, and we got that through the University of Otago Ethics Committee Health. I've also worked with Melina in undertaking the Māori consultation for the project, and we obtained that through the Canterbury District Health Board process. I'll also be leading the data collection, analysis and write-up of the outputs. So the study itself, we're using semi-structured interviews to explore the views of people about their interactions with the service in Canterbury. We've got a broad inclusion criteria to assist with getting a wide variety of experiences. We're inviting English-speaking clients over the age of 18. We've been engaged with the MND Clinical Nurse Specialist in MND Clinic for more than a month. We'll include people who use a device to speak. After gaining consent, we're going to be offering a variety of ways for participants to contribute. So email, phone, face-to-face, or a combination, or Zoom, or whatever is going to suit the participant. Carers and partners can also contribute to the facilitation of participant responses to the question. And I'm just going to outline a little bit how we've managed to keep the clinical aspects of people's care and the research data collection process separate. So Rachel was involved with pre-screening of potential clients, and she provides a list of those potential people to Melina. Melina then approaches these people via email or phone to ask if they're interested in participating in the study. For those people who indicate that they're interested, their contact details are then passed on to me, and I have absolutely nothing to do with the clinical side of people's care in Canterbury. I then make contact with anyone who's interested via email. I introduce myself, also provide a copy of the information sheet about the study, the consent form, and a copy of the questions that we're going to ask so people know the sort of direction of the study. And people who contact me and provide a consent form or indicate via email that they'd like to be involved are then invited to let me know how they would like to be interviewed. So screening and contact and invitation to participate is currently underway. We're aiming to recruit around 12 people and hopefully interview around 8 to 10. And I'm in the process of interviewing 3 people. And we're going to be offering participants a small thank you gift for taking part, talking with us at the end of the study. We're also aware that people might be reluctant to speak freely if they think that their treatment team might find out what's been said. So we're doing everything we can to reassure people that their answers will be confidential, and that the research process is removed from their usual care. And additionally, Rachel won't be participating in the interviews, and nor will she see the raw interview data. Anything she sees will be de-identified. Just to explain a little bit about the data analysis process, we're going to use a thematic process and an inductive approach. So that means we're going to be looking for themes across the different interviews, and we're using themes that arise from the data. We've not gone in with any preconceived notions about what we think people are going to tell us about the service, because I actually know absolutely nothing about it. So I'm a completely naive researcher in that regard.
And so to talk to the quantitative aspect, this is going to be an audit of pre-existing hospital records from clients in Canterbury with motor neuron disease who were diagnosed between 2007 and 2020. And so my role in this is kind of data collection from those records and entry into a database over 10 weeks while I do the summer studentship role. And as this is a respective audit, there isn't any requirement for ethics approval it's all confidential and no NHIs will be shared, or no contact with patients will be required. And so the aims of this aspect specifically is kind of to establish some prevalence and incidence data, median survival from diagnosis and from symptom onset for Canterbury within that period that I just said. And that'll kind of build on some previous work, while we also look to assess any change in hospital usage or timing of interventions, both before and after the initiation of the clinical nurse specialist role in 2013. So patients that are included in this audit will be those diagnosed with motor neuron disease by Canterbury District Health Board neurologists between 2007 and 2020. And then the NHIs of these patients have and will be collected from multiple sources. So primarily there is a neurology database of all diagnoses going back to, I think, 1985, so quite a large resource there, which we have requested access to. And then kind of we've also have access to the clinical nurse specialist has maintained her own record of all the patients she's interacted with. So we have quite thorough data there from about 2013 when that role came in. So that'll be good for cross-referencing that data. And we've also contacted all the privately practicing neurologists in Christchurch to see if we can catch anyone that may have slipped through the cracks and not gone through the public system. And there's also, we have some access to some data which is of hospital admission data across that same period. So again, that's been using the ICD code search, which includes motor neuron disease. So again, between all those sources, we should hopefully be quite confident that we've caught all the MND patients that have been in Canterbury during that period. As far as which time period we've gone for, we've chosen to do 2 5-year cohorts, one prior to 2013 and one post 2013. And we've done this just to kind of hopefully still get a significantly large pool of patients, but that can be reasonably analysed by myself during that kind of short 10-week period. And so for this reason, we've chosen two time periods. So one is from the start of 2008 to the end of 2012, just before the CNS role was created, and then one starting in 2015 and ending in 2019. And the reason that we chose not to go for the most current data there, as far as including 2020, is after a bit of consultation, we decided that there's probably quite a significant impact of the 2020 COVID lockdowns on hospital admission data and access to outpatient clinics and things like that. So that would have a quite significant impact on any data we'd hope to get. And then a little bit more about this. I see it as there's 2 aspects to what I'm doing. Part 1 is building on some previous work done, namely this study here, increasing incidence of ALS in Canterbury by Murphy et al. So this was a study measuring incidence from 1985 to 2006 within Canterbury, and they had quite a similar method to us. Or we have a similar method to them rather. And so this aspect of the work is kind of where it comes in just for assessing the incidence and the prevalence and mean survival from those time points of diagnosis and symptom onset. And then for those analyses, we'll have to interpolate between census data points to estimate the population. And then the second aspect is kind of going beyond and assessing the impact of this clinical nurse specialist role that we have only in Canterbury currently. And so for this, we'll be comparing those 2 cohorts for kind of some key clinical outcomes that we think will be important and could potentially show an improvement in care or a change in care there. And there's also the interesting opportunity to assess the impact of riluzole therapy, particularly for those with the ALS subtype of motor neuron disease. as this medication was not funded during the period of this earlier study, and only about 7 patients were taking it, as it wasn't there wasn't the funding ability there. So just briefly, we have quite a long list of things that I'll be collecting from the health data, but we'll be assessing demographic data, and then also some kind of key diagnostic materials, such as which specific subtype they were diagnosed with, what their primary symptoms were, so like a bulbar versus a spinal onset, the presence of upper versus lower motor neuron signs at diagnosis, the number of admissions they've had, how long those admissions were, the number of outpatient visits that they've had post-diagnosis, and with how many different specialties, so neurology, respiratory, kind of just any contact there, and then kind of key set clinical dates as far as timing of having a feeding tube installed, and any date of commencing BiPAP therapy, how long they might have been on riluzole if they were on, and if they have unfortunately deceased, the date and the location of that event. And then from there, we'll kind of analyse a little bit further to establish incidence, prevalence, get mean and median ages of diagnosis, symptom onset, assess the delay between onset and diagnosis, and then kind of check survival before and after the placement of feeding tubes and commencing non-invasive ventilation. And then as of the start of this week, we consulted with a biostatistician, Dr. Jonathan Williman, to kind of plan out how we will analyse our compiled data. I will personally be able to perform some descriptive analysis and calculate the incidence and prevalence, but more complicated analysis of kind of survival data involving life table analysis and kind of time interval analysis will kind of be a little bit beyond the scope of what I can learn and perform within the 10 weeks. So that will be carried out by another member of the team. And so kind of in this way as well, the work that I'm doing is just kind of providing a bit of a platform for further work that will need to be done before any kind of publishing of kind of a formal paper or review to the Motor Neuron Disease Association. And then lastly, just kind of what outcomes we're trying to get here with this work is kind of current incidence, prevalence and mortality data is always important as it informs the health system about any burden of disease and kind of any need for our services both within Canterbury and nationally, kind of how they're performing and where they need to go. And so hopefully we'll see an improvement in patient outcomes for these clinical endpoints after having this role and the multidisciplinary clinic in Canterbury. And then as far as bringing in the qualitative aspects, having both hospital data and patient opinions and feedback will help to strengthen kind of any of this evidence that we think should be there, hopefully. And it can also help to elucidate any changes or improvements that we think will need to be made to the service going forward, both here and as it is brought in other regions within New Zealand. And then just, yeah, as New Zealand has one of the highest incidences of motor neuron disease in the world, any service improvement that can arise from this will benefit a large number of people or a significant group of people. And so any learnings from this study will also inform development of services elsewhere, and they can also produce data that we hope to disseminate throughout a number of channels. So we have a planned report to the Motor Neuron Disease Association, and there's potential for 1 or 2 publications in suitable journals once all the work is completed. So on behalf of the team, I'd like to once again thank the Motor Neuron Disease Association for the funding of this project. And with that being said, we welcome any questions from the floor.
Thanks for that, Mandy and Justin. That was fantastic. I'm looking forward to hearing more about the results. Can I ask whether you're capturing information about people's interactions with genetic services and whether people are receiving genetic diagnoses?
We haven't kind of formally got that as one of our things that we're assessing, but due to the nature of how I'm having to search through kind of health records and health clinic south, that's the kind of thing that I can probably actually go away and consult with the team and see if we bring that in, because as I've just kind of done some preliminary searches, there has been there'll be reports from genetic services, so kind of there is room where we could think about bringing that in. So not at the moment, but I can talk to the team and see if they think that would be something to bring in. So
yeah, I think it's a really important question, and one that Alan discussed how the pathway to genetic testing for everyone with MND is yet to be worked out. So I'm going to be part of the group that advises or puts together some recommendations around that. But I think what we also lack is really good information about how people are getting genetic diagnoses in the first place and whether it's already changing. So from our end, we'd like to go back to the genetic services and genetic testing providers in New Zealand and ask them whether the level of requesting genetic tests has gone up. But from your end, you can find out whether the patients themselves are receiving genetic diagnoses, if they're offered genetic counselling, what their experience actually is through their health records. So that will be very interesting.
Thank you very much. It's really interesting, the work that you're doing, and yeah, seeing the results. I'm really keen to see how it rolls out. I'm just wondering, do you, with the qualitative aspect of the study, is there like a number of participants that you hope to recruit? Do you have a kind of a target number, or?
Yeah, we're hoping to recruit around 12 and interview about 8 to 10 people.
Okay. Yeah, I think it's quite timely, this research, just having listened to the guidelines that are going to be rolled out, and definitely it will help strengthen the evidence to have more clinical nurse specialists for MND throughout the country, because I'm sure it's making a huge difference to the population down there.
One thing I'll point out to the team, in the past, people in Canterbury.
In the past, people in Canterbury.
Because they've got access to CNS.
Because they've got access to CNS.
And a support worker.
And a support worker.
They can mix them up.
They can mix them up.
So you'll need to be very careful.
So you'll need to be very careful.
And make sure they're talking about the right person.
And make sure they're talking about the right person.
And then to go so far as to take a photo of Heather and Alan.
And go so far as to take a photo of Heather and Raywin. Otherwise they'll mix it up.
Tony, do you want to comment? Tony, do you want to?
Tony, do you want to comment?
Yep, I was just going to say the same thing, that people do get confused about the two roles. It would also be really good to know how, from the client's perspective, how they felt the two roles worked together and how they could complement one another, what could be done to improve that. And possibly explaining that, our role is outside the DHB, because a lot of people do get confused and think that our support advisors are funded by the DHB and part of the healthcare system, or part of the DHB system. So just clarity around that and how the two roles work together would be really good from our perspective, particularly if we're looking at trying to establish this in other parts of New Zealand, which is what the Clinical Working Group would like to do. If we could kind of have a template to go, this is how it works, it would be great.
Okay, I will see what I can wangle with the team.
Yeah.
And I will make sure that the people that I've talked to so far have been very clear about who they were talking about. So,
and
Very definitely talking about the clinical nurse specialist.
Yeah. And if you need help with the names of who the support team member was during those years, I can give you those too.
Cool. Okay.
Helpful.
Our thinking is that you need someone with access to within the health system.
And our thinking is you'll need someone with access within the health system
Who can help with clinical care.
who can help with clinical care.
And then the separate role
And then, the separate one
is the support worker. They're more addressed to providing information and emotional support.
and the support worker is more bridged.
Is more providing emotional and information
Is more providing emotional
support.
and information.
That's how we look at it at the moment.
That's how we'll sorry.
That's how we look at it.
That's how we look at it at the moment.
But whatever you find will be interesting to see how patients see those roles.
But whatever you find will be interesting to see how patients will find those roles. See those roles.
Thanks, Claire. I really appreciate that insight.
And with the support advisors, we work with the whole family. So we're there for not just the client, but the carers and their extended whānau, and also the health professionals working alongside, particularly in the smaller areas. We find that we do give a lot of support to the health professionals as a bit of a sounding board, and obviously it's a very tough role that they're working in, so we kind of network with that and the other social services. So that gives us, a bit of a benefit with being outside the DHB. We're not constrained with anything that's set by the DHB.
Yep. Do you mind me asking what the background is of the key workers, support advisors?
Support advisors? It varies. Most of us have a health professional background. Currently on the staff we have 2 RNs, a speech language therapist, physiotherapist, and a couple with a special needs education background. Sorry, I had to think then. Or they've come from other support roles in the disability sector. So maybe Stroke Foundation or Disability with Children and dementia.
So are they funded by the MND Association?
Yes, they are. So we get a small payment from the Ministry of Health to provide an information service that covers about 7% of our running costs. The rest is through fundraising, grants and bequests.
Okay.
And there are 8 in the support team currently. Watch this space because it may be expanding.
Cool.
A good example for key difference.
A good example for key
of and key difference.
Sorry.
A good example might be that if their CNS could go into a home, the person says I'm having trouble with BiPAP, they could liaise with a respiratory physician to sort it out. But our support workers are limited in that, from that point of view. Did you get that, Tony?
I did. Yeah. So you say that the clinical nurse specialist has access to the clinical respiratory physician, but the support workers don't necessarily have that pathway. Yeah.
We do. Yeah, we do. But it's not as strong.
Easy. Yeah.
I mean, it depends where you are. Obviously we're home based and we're not everywhere in the country, but people have outreach areas and do travel. We do attend multidisciplinary team meetings. We are kind of included as part of the healthcare team with that respect. And a lot of those are by Zoom now, so we can attend those more easily. But I think the CNS would have more sway, and it depends what area you're in. Like, you know, often we have really good networks and can just ring up an OT or the CNS for respiratory in Auckland. We work really closely with her and we can make a referral, but I think having someone within the DHB system makes that pathway a lot smoother or a lot quicker. Yeah. So it depends what area you're in, how you work, if you're a support team, you know, support advisor.
Yeah, I think our support workers have been doing a great job of filling gaps.
Yeah, yeah.
Hopefully that gives you some context. Hopefully that gives you
some context.
It definitely does. Thank you very, very much. Appreciate that.
Okay, well, thank you. That was a good discussion, and thank you, Mandy and Justin. Best of luck with the research. And Justin, I think you've got a couple of busy months ahead. It sounds like you're going to be doing quite a lot. So yeah, we look forward to hearing the results of the study once it's all finished.
Thank you.
Thank you.
Good luck. And yeah, we're here if you need anything.
So I guess we can finish up. I would just like to say a few words. Thanks very much again to all of our speakers today for your time and for your passion to improve the resources and the services for people with MND, particularly in New Zealand. And I'd also like to thank our audience for taking the time to join us this morning. And I hope that you enjoyed it and took something away from today's presentations. I'll be emailing out a recording of the webinar to everyone on our mailing list in the coming weeks, and it'll also be posted on our website. So if there's anybody that you know that couldn't make it today, but that would like to listen to the recording, then please share it with them. Just to save the date for next year, there is going to be an Australian and New Zealand MND Research Symposium. It will be happening from the 17th to the 19th of March in Brisbane. More details are to follow, but we will be keeping you updated on social media and for people on our mailing list as well once we know a little bit more about it. And I'd also just like to let you know that there is 2 masters and 1 PhD research opportunity that is currently available. I know Alan spoke about one today, but applications are open and you can read more about them on our website under opportunities for researchers. So if you know anybody that is interested in doing some research within the MND circle, then please get them to have a look at that website. And as this is our last gathering for 2021, I just want to thank all of our supporters who have participated in the network over the year, those who have attended and presented at our teleconferences, supported us with the Cup of Tea for MND event, and those who joined the network this year, and all New Zealanders who are passionate about MND research. We're looking forward to more networking opportunities in 2022 and hearing an update on the upcoming MND research that was presented today, as well as other studies that are happening in New Zealand. So I wish you all a safe and happy Christmas and New Year. I hope you managed to get some time to rest during the summer holidays and look forward to seeing you next year. Tēnei koutou.
Thanks, Debla.
Thank you.
Thank you.
Kia ora, everyone.